My name is Darren Kies. I'm an interventional radiologist. I'm the chief of interventional radiology for a private practice group called Piedmont South Imaging, and we provide services to Piedmont Fayette Hospital and Piedmont Noonan Hospital in the south and southwest metropolitan area of Atlanta. So when would an oncologist need an interventional pulmonologist to assist with lung cancer is a very good question. And it's actually kind of better framed to discuss it along with interventional radiology, which is what I do. So, both have interventional in the title. So you can imagine both of these doctors do some sort of invasive procedure. An interventional pulmonologist is someone who started out going down the medicine training arc and then specialized in pulmonology. And then after doing a pulmonology fellowship, does an extra year of training to learn to do invasive procedures that are, centered around the lungs. And really a lot of this is centered around doing bronchoscopy and interventions associated with bronchoscopy. So, placing special video cameras down the airway into the smaller airways in the lungs, and then doing biopsy procedures or placing stents or doing alveolar lavage and different things to try to diagnose and solve problems within the lungs. Interventional pulmonologists can also place chest tubes, and there's, there's some interventional pulmonologists who do tracheostomies. So there's a lot of different things they can do, and there's certainly things that cross paths with interventional radiology. I think for what the oncologist needs to know is when do they need to call an interventional pulmonologist when they have a problem versus when do they need to call an interventional radiologist. Hopefully, in whatever setting they're working with, if they're treating a lot of lung cancer, they've got a good relationship with both doctors, and ideally they all get together weekly or every other week for a tumor board and they can talk about these things in person. But one of the big questions that always comes up is when do you need to talk to an interventional pulmonologist about getting a lung biopsy, and when do you need to talk to an interventional radiologist? And luckily, the way that our procedures are performed, they're kind of, they complement each other in the fact that the things that are difficult for me to do with percutaneous tissue sampling is easier for an interventional pulmonologist to do, and vice versa. The things that are difficult for them to diagnose and get to are easier for us to get to. So, going back to interventional radiology and percutaneous tissue biopsy, we're really good at sampling tissues the farther out they are from the hilum of the lung. As a lung mass gets closer to the central hilum of the lung, that's like the business part of the lung. That's where all the big blood vessels are. That's where the large central airways are. Doing a percutaneous biopsy in that region becomes just more risky. There's an increased risk of bleeding. There's an increased risk of getting a pneumothorax. Not only because there's larger vessels surrounding there, but you have to cross so many other structures with your needles in order to get there. It just increases the risk for the patient. Whereas for an interventional pulmonologist, their interventions basically start at the hilum of the trachea, or at the hilum of the lung, where they can use an ultrasound to guide a needle, and they can sample tissues in the mediastinum. They can sample tissues right in and around the hilum. There are some interventional pulmonologists that do what's called, it's kind of a navigational bronchoscopy, where they can use real-time computer kind of GPS monitoring to help guide their bronchoscope further out into some of these smaller airways, and sometimes sample masses that are a little bit farther out. But again, the farther away you get from the hilum, it's going to be much more difficult to get a scope into that small little airway and sample tissue effectively, whereas the stuff that's more in the periphery of the lung is stuff that we can easily get a needle into. So if you keep that as a rule of thumb, the more central a lesion, you're going to want to be talking to interventional pulmonology. The more peripheral lesion, you're going to want to be talking to interventional radiology. That will really take you a long way. One other thing to consider when you're talking to the two service lines is what you need, what kind of answer you're looking for. And some of this has gotten better with time as technology has improved, but traditional thinking and the traditional way of thinking about it is that, interventional pulmonology are doing what's called fine needle aspirations. So they're placing either a 21 or a 22 gauge needle into their target lesion, and they're not truly obtaining a core biopsy sample. And the difference between a fine needle aspirate and a core biopsy sample is a core biopsy sample is a much larger pieces of tissue that maintains some of the normal cellular architecture around whatever you're sampling. So you can do better molecular profiling, you can run DNA tests, you can just get more answers out of some of these next generation type tests that we perform now with a core sample than you necessarily can with a fine needle sample. Now, all that being said, you know, that's a recognized problem. So they've developed better needles for these fine needle aspirates that do provide some of that core-like samples. So it's a little bit murky, and sometimes you can get the answer either way. But in general, if this is a new diagnosis of a cancer, and you really need, you're going to need to do sequencing and all that, you're better off getting a core sample, and that might kind of push you towards doing a percutaneous biopsy, all things being equal. If you're just trying to, say, let's use the example of metastatic disease, and you have a patient that has some nodes in their hilum, and they have a known primary somewhere else, and you have all the tissue in the world you need. All you need to do is show that there's malignant cells in this lymph node. That's a very good case for just to do a fine needle aspirate. So, those are some of the things about interventional pulmonology and when you would call one or the other. Again, that they have the ability to place stents in the airway, which I think is very important for some of these endobronchial lesions that oncologists will come across. And there's a lot of really, there's always something new on the horizon. But I think, in summary, both service lines work, well together, and they kind of complement each other's skill sets. And I think having both at disposal is really important for a busy lung cancer practice.